Why don't we go get started this morning? It is a real treat, a pleasure, and delight for me to introduce our speaker this morning, Dr. Philip Greenland, who joins us from Northwestern. Dr. Greenland has had the kind of career that could fill up the full hour if I presented all of his major accomplishments. So I'll just try to be extremely brief. You can see here is the Harry Digman Professor of Cardiology. He's held a number of distinguished positions at Northwestern, including being the Department Chair for Preventive Medicine and the Senior Associate Dean for Clinical and Translational Research. He's been the editor of JAMA Internal Medicine and a senior editor at JAMA. He is a cardiologist whose career has really been focused on prevention, and he's had leading roles in a variety of large-scale epidemiologic studies, including MESA, Cardia, Women's Health Initiative, and various others. It's delightful to actually be working with him on a epidemiologic study in MESA, Rotterdam, and the Dallas Heart Study looking at metabolomics and atrial fibrillation. He's received numerous honors from various organizations. Notably, he's an elected member of the Association of American Physicians, and he continues to be a prolific investigator in a variety of fields related to prevention, both of atherosclerotic heart disease, atrial fibrillation, and various other cardiac conditions, including cardiovascular consequences following adverse pregnancy. So we're really delighted to have Dr. Greenland with us this morning, and look forward to your talk. Thank you, Phil.
Thanks, Jeff. It's really an honor to be invited to speak at the Cardiology Grand Rounds, and I'm sorry that I'm not there in person, but very pleased to be with you this morning virtually. So as Jeff said, the topic is cardiovascular consequences following adverse pregnancy outcomes. Let's see here. It's going to let me advance. Okay. Looks like it's not going to let me advance. So let's see what happens here. You're probably seeing on the screen both the slide and the next slide, but let's see if I can do that. Sorry about that. Present your view is what it says here. Okay. Are you seeing that, the presenter view now?
Yes.
Okay. Again, having not advancing. Oh, there we go. All right. Okay, so here's my disclosures. I have grants from NIH and AHA and no relationships with industry. I want to start with just indicating how the guidelines related to cardiovascular disease in women have changed actually quite dramatically in the last 10 years. And I want to start with this slide going back to 1991. 30 years ago, this was an editorial in the New England Journal of Medicine by Bernadine Healy, who many of you know at the time was the director of the NIH. And Dr. Healy was a distinguished cardiologist. She started her career at Johns Hopkins, did a number of major studies related to coronary care, intensive care. But at the time that she became director of the NIH, she was quite interested in the problem of heart disease in women. And following the publication of a couple of papers in the New England Journal in 1991, she wrote this editorial in which she talked about the fact that the research on heart disease had been mainly male focused. And like the story of Yentl, who was a young girl who wanted to study the major Jewish text, she had to dress herself up as a male to get attention. What Dr. Healy was pointing out is that that is sort of the problem that women were having at the time, that they were not really recognized as having any special cardiovascular risks. And in 1991, as many of you know, she initiated what's now come to be known as the Women's Health Initiative, which is a study that's been ongoing for 30 years. And that study has resulted in close to 2,000 papers related to heart disease in women. But despite that, in 2007, when the American Heart Association published a guideline on cardiovascular disease prevention in women, the table that's shown on the right here, indicating areas of risk, high risk and others at risk. If you look down the list here, cardiovascular consequences of adverse pregnancy outcome was not even put in the list, indicating that what was considered to be the priority at the time, that trying to understand the history of someone's pregnancy outcomes wasn't regarded as important enough compared to the other risk factors like cigarette smoking, poor diet, et cetera. I would point out, however, that there was a note in the text of that 2007 guideline indicating that there were unique opportunities to identify women's risks during pregnancy. And these, at the time, they said deserve further exploration. And they only indicated two references that I've given here, a reference from 2003 and another one from 2005, suggesting that there were potential long-term risks of cardiovascular disease following adverse pregnancy outcome. The next update of that guideline was 4 years later, 2011. And by 2011, which is pretty recent, history of preeclampsia, gestational diabetes, and pregnancy-induced hypertension were finally added to the list of risk factors that should be considered in women. And the text over here points out, because of unique cardiovascular and metabolic stress, pregnancy provides a unique opportunity to estimate a woman's lifetime risk. And it points out that in a large meta-analysis, which I'm going to review a little bit later in the talk, women with a history of preeclampsia have approximately double the risk of ischemic heart disease, stroke, and venous thromboembolic events over the 5 to 15 years after pregnancy. And subsequent guidelines have really emphasized this quite a bit. And I think that as cardiologists, we're beginning to pay much more attention to this area. But as I'll show you later on, this is still an area that's evolving. There's still a significant need for more research in this area. And at the end of the talk, I'm going to suggest the possibility that possibly some of you might be interested in getting involved in some of that research. So in 2018, the American Heart Association published this guideline in concert with the American College of Obstetrics and Gynecologists. And as far as I know, this is the first instance in which the American Heart Association and the ACOG joined hands to emphasize the importance of cardiovascular disease in women and the pregnancy-related risks. And I'll come back to this later in the talk. But this guideline specifically indicated that adverse pregnancy outcomes was a risk factor for cardiovascular disease in women. And then lastly, this guideline just came out. This scientific statement from the AHA just came out, entirely focused on adverse pregnancy outcomes and cardiovascular risks. And this is a summary of the findings and implications of that statement. And they pointed out here that adverse pregnancy outcomes, and they listed specifically the ones that are most strongly associated with cardiovascular disease, hypertensive disorders of pregnancy, which I'll define a little bit more later, preterm delivery, gestational diabetes, small for gestational age delivery, placental abruption, and pregnancy loss. All of those are associated with an increase in a woman's risk of developing cardiovascular risk factors and later CVD. And second, that getting a history of APO, of adverse pregnancy outcome, and I emphasize this, their language was that this is essential when evaluating cardiovascular disease risk in women. And they do appreciate and point out that this may or may not end up reclassifying risk, but at least it gives a heightened sensitivity to the long-term risk and how to deal with that. They suggest more vigorous primordial prevention of CVD risk factors. I'll come back to that as well, about why that is important, and emphasizing the healthy heart diet and similar kinds of primary prevention efforts in women. So I want to transition to giving a few examples here of the importance of the epidemiologic aspects of cardiovascular disease in women, just to put some of this in context. I think that probably the information on this slide is well known to people in, at University of Miami, but let me just review it quickly. The left-hand side points out that 1 in 3 women will die from heart disease each year. 9 out of 10 women have at least one or more traditional risk factors for developing heart disease. And I would point out that's true in men as well. But what's a little bit disheartening is that despite all the emphasis that's been given to overcoming the Yentl syndrome since 1991, this slide points out that 4 in 10 women in 2019 identified cardiovascular disease as their leading cause of death, which was actually down from 6 in 10 in 2009. So we have a lot of work to do in the cardiovascular community to help women understand the importance of cardiovascular disease risk. This slide shows something else that's, I think, critically important about cardiovascular disease in the United States, and that is, this slide shows the data only for women, but it's true for men as well, that up until about 10 years ago, the cardiovascular disease death rates in the United States were declining. So this is for Black women. This is the black line here is overall women, and the purple line here is for white women. And there were declines that were seen up until about 2011. But from 2011 onward, and this has been true in the most recent surveys as well, that the cardiovascular disease death rates in America for men and women have flattened. And there's even some recent evidence that the cardiovascular mortality rates in the United States are starting to creep up. So again, it emphasizes the importance that all of us need to pay more attention to efforts to prevent cardiovascular disease as best we can. And you can see here that there's a large difference in the mortality rates in Black women compared to white women. All right, let's see here. My slides skipped too much. All right, so with that background, I now want to transition to talking much more focused way on adverse pregnancy outcomes. And on this slide, I just want to spend a minute or so talking about what the different adverse pregnancy outcomes are that we identify. Have to say, when I started getting into this topic area, I had to remind myself of what these different definitions were, because I really hadn't dealt with this since medical school. But when we refer to hypertensive disorders of pregnancy, we're talking about several different adverse pregnancy outcomes: gestational hypertension, chronic hypertension, and preeclampsia, all of which are associated with hypertension in pregnancy. Gestational hypertension is new onset hypertension, which OBGYNs define in the using the categories of blood pressure that we used to use. I think the OBGYNs are starting to update this to the lower systolic and diastolic levels that we're using now in the AHA guidelines, but this was the definition up until several years ago. Preeclampsia, probably familiar to most of us, new onset hypertension after 20 weeks of gestation, associated with proteinuria or evidence of end organ dysfunction, and obviously associated with higher risk of fetal loss and maternal mortality. Chronic hypertension, obviously hypertension before 20 weeks of gestation or pre-existing hypertension. Gestational diabetes is often included in the list, but it's not considered a vascular complication of pregnancy. And so when we look at cardiovascular consequences of adverse pregnancy outcomes, frequently gestational diabetes is not included in the list. But preterm birth is usually included in the list, as well as early preterm birth. And that's because there's evidence that those adverse pregnancy outcomes are also related to vascular abnormalities of the placenta during pregnancy. So there appears to be a connection between gestational hypertension, preterm birth, and small for gestational age birth. There's also been a lot of interest in trying to understand the incidence of adverse pregnancy outcomes, and there's quite good evidence, unfortunately, that adverse pregnancy outcomes are becoming more common. This is some data from a study conducted just a few years ago in the United States using National Center for Health Statistics natality files. So these are public records, 51 million live births, and this is a cross-sectional analysis using serial cross-sectional data concerning adverse pregnancy outcomes. The adverse pregnancy outcomes that were studied in this report included the ones that I mentioned before: low birth weight, preterm delivery, gestational hypertension, and preeclampsia. What I'm going to show on the next set of slides is adverse pregnancy outcomes per 1,000 live births using a program called Joint Point, which is trying to understand the trends. And I'll be showing some data on subgroups, age subgroups, and race ethnicity subgroups as well. So the evidence from the public data sets indicates that adverse pregnancy outcomes are unfortunately increasing. And approximately 2014 is where the time point is when the rate started to go up. And as I'll show you on the next couple of slides, it looks like gestational hypertensive disease of pregnancy, which includes preeclampsia, gestational hypertension, and chronic hypertension, as I showed on the earlier slide, that this is really where the increase is coming from. Low birth weight and preterm birth are essentially flat, but hypertensive diseases of pregnancy have been on the rise. And that's shown here. You can see for low birth weight and preterm delivery, the rates are approximately flat across non-Hispanic white, non-Hispanic Black, Hispanic, and Asian women. But for all four of those racial ethnic groups, what we see is an increase in the rate of hypertensive disorders of pregnancy. Also, across every single age group that the survey looked at, hypertensive disorder of pregnancy has been going up. And of course, the highest rates are in the oldest women, whereas low birth weight and preterm delivery have been relatively flat. So what's going on here? One of the things that's going on is that pre-pregnancy hypertension is a risk factor for hypertensive disease of pregnancy. And this is a paper from one of our fellows at Northwestern, published in JACC last year. And again, she's using public data sets showing the prevalence of maternal pre-pregnancy hypertension in rural and urban areas in the United States. And obviously what's going on here is that pre-pregnancy hypertension has been on the rise. And unfortunately, pre-pregnancy hypertension is one of the strongest risk factors for hypertensive disease of pregnancy. So this is an area, I think, again, that all of us in cardiology and cardiovascular disease prevention need to pay a lot more attention to. And these rates probably are underestimated because, as we all know, we've redefined what represents hypertension, and probably the absolute rates, absolute prevalence is even higher than what's shown on this slide. And another thing that's indicated on this slide is that the rate ratios of hypertension for rural compared to urban areas has remained elevated. So rural areas of the United States have had higher risk of maternal pre-pregnancy hypertension for a number of years now. Other risk factors for preeclampsia include BMI, so higher BMI both in multiparous women and nulliparous women. So the highest risks of preeclampsia appear to be in nulliparous women, and that's probably a bit of an artifact because women who have very complicated pregnancies often don't try to have a subsequent pregnancy. So what we see is that the risk of preeclampsia tends to be much higher in first pregnancy nulliparous women compared to multiparous women. But there's this very strong association between higher BMI and higher risk of preeclampsia. The same is true of early preeclampsia here. And I think this is my last epidemiology slide. The risk of preeclampsia by interpregnancy BMI change is also important. Women who gain more weight after their first pregnancy are also at higher risk of developing preeclampsia in later pregnancies. So this is just to summarize what I've reviewed so far about recent trends in APO. The rates have been increasing in the United States. Hypertensive disease of pregnancy has increased the most dramatically. I didn't really mention this, but in aggregate, all of the APOs that I've talked about occur in about 20% of first pregnancies in the United States. So this is a very highly prevalent problem. And adverse pregnancy outcomes occur more commonly in women who have pre-existing cardiovascular risk factors such as hypertension and overweight. Okay, I want to discuss now where I think the cardiologist is probably most likely to get involved in this area, and that is understanding the cardiovascular risks that are associated with adverse pregnancy outcomes, short-term and long-term. So in this slide, what I'm showing is that there is a near-term risk associated with cardiovascular mortality during the pregnancy itself for maternal cardiovascular death. And the United States is doing particularly bad in this area. All of these other countries, UK, Portugal, Germany, etc., have been showing reductions in maternal mortality associated with adverse pregnancy outcome up until 2015. But the United States has actually had an increase. And our rate is considerably higher than most of the rest of the similar countries around the world. So obviously this is a problem that's mostly confronting obstetricians and gynecologists, since this is, maternal mortality during pregnancy. But the evidence is clear that after an adverse pregnancy outcome, women who have those complications of pregnancy show evidence that their cardiovascular risk is remaining elevated. And when I first started paying attention to this area, I was a little bit surprised because years ago, what used to be taught about preeclampsia was that it was a disease of pregnancy, that if you could deliver the baby and save the baby and the mother during pregnancy, that the woman would return to completely normal. But the evidence is not showing that. This is a paper recently published in JAMA Network Open. And this is just in the 6 weeks postpartum. This is systolic blood pressure trajectory in Black women and white women, diastolic blood pressure trajectory. And what it's showing is that for both Black and white women over the 6 weeks after delivery, blood pressure tends to go down, but remains higher in Black women compared to white women. And you can see here that for Black women overall, by 6 weeks after delivery, the systolic blood pressure level is above optimal on average, above 120. This slide is showing something I think also that's quite important. This is from a study in Norway, but it's very similar to what's been shown in the United States. These are life course trajectories for cardiovascular risk factors with and without hypertensive disorders in their first pregnancy. This is from a very important long-term study from Norway called the Hunt study. These data were published in JAHA. within the last couple of years. And what they show, the solid line is women who were normotensive during pregnancy, and the dashed line is women who had preeclampsia during pregnancy, and the shading is the 95% confidence intervals. And what you can see here is, of course, we know that this is the case even among women who didn't have hypertensive disease in pregnancy, preeclampsia. Blood pressure tends to rise with age. But in women who had preeclampsia, they started out higher in their 20s, and their systolic blood pressure levels reached quite high by age 60. Same was true for diastolic. BMIs were higher and remained higher over the life course. Waist circumference was higher and remained higher over the life course. Hip circumference the same, waist to hip ratio the same. So these data are indicating that women who have preeclampsia seem to have higher cardiovascular risk factors shortly after the pregnancy is over, and they remain higher during their entire life course. What about other evidence that women who have preeclampsia or other cardiovascular complications, other adverse pregnancy outcomes, have long-term risk of cardiovascular disease? This is the meta-analysis that I referred to earlier at the very beginning of the talk. This was published in the BMJ in 2007, and I don't know if there's any medical students in the audience here today, but the lead author on this paper was a medical student from London. And what these data are looking at is published studies on the long-term risk of cardiovascular disease and cancer, and the association with preeclampsia. So this is the list of the studies that they were looking at. This is the number of cases here, total number of cases, and women who had preeclampsia, total number of cases, women who did not have preeclampsia, et cetera, and the relative risks reported in each of these studies. And what you can see here, this is for hypertension risk, and overall, the aggregate effect was about between a 2- and 5-fold higher risk for hypertension after preeclampsia. This slide is for ischemic heart disease, and a smaller number of published studies. But as I indicated at the earlier when talking about the guidelines, the evidence suggests that there's about a 2-fold higher risk long-term of ischemic heart disease following preeclampsia. So these are, again, lifetime risks. Women who have preeclampsia have about a 2-fold higher risk compared to women who don't have preeclampsia. This is a different meta-analysis reporting on composite cardiovascular disease and ischemic heart disease. And this slide breaks it out by different types of adverse pregnancy outcomes: moderate preeclampsia, severe preeclampsia, stillbirth, preeclampsia, preterm birth, et cetera. And what you can see here is that for all of those different adverse pregnancy outcomes, there has been published reports indicating higher long-term risk of total cardiovascular disease and higher long-term risk of ischemic heart disease. And lastly, I just want to mention this paper that was published a few years ago in JAMA Cardiology, looking at cardiac disease and death in women whose infant was preterm or small for gestational age. And this was a rather large study. It was a cumulative probability of maternal composite cardiac outcomes from Ontario, Canada. This is hundreds of thousands of cases from the electronic health record data over a 15-year period, 2002 to 2016. And what it's showing here, obviously, is that in the years following the preterm birth or small for gestational age birth, there was an increasing risk of cardiovascular disease over the subsequent 14 years compared to women who had neither. So here's the trajectory for women who had neither of those outcomes. This is the trajectory for women who had term birth with small for gestational age. This is preterm birth without that, and this is the curve for people who had, unfortunately, both outcomes. So what's going on in terms of the long-term risk? How do we understand it? What's the explanation for it? So there have been a relatively small number of studies in this area. And I think this is an area where there's a great opportunity for cardiologists to get on board and help elucidate what's going on in women who have adverse pregnancy outcomes. This is a paper that was published this year in JACC. It's based on an observational study of women who reported hypertensive disorder of pregnancy. So what they did was they got echocardiograms in women who reported adverse hypertensive disorder of pregnancy. The echocardiograms were taken about 8 to 10 years after the delivery. And in women who had normotensive pregnancy and were not currently hypertensive, they looked at interventricular septal wall thickness, they looked at LV wall remodeling, and they looked at mitral inflow. And these values were relatively normal in women who had normotensive pregnancy. Women who had hypertensive disorder of pregnancy, their values were all higher. People who had current hypertension, the same, and women who had hypertensive disorder of pregnancy and current hypertension had the highest values for wall thickness, for septal wall thickness, for wall remodeling, and the worst values for mitral inflow, E to A ratio. So the suggestion is that what's going on is that not only are they having a consequence of their pregnancy that may lead to hypertension after pregnancy, but that set of abnormalities is associated with cardiac structural abnormalities as well. Want to just briefly point out a review article that was written by one of our fellows and several of our faculty at Northwestern, including myself, published in JACC in 2019. And in this paper, we tried to summarize not only the long-term cardiovascular risk, but to try to highlight some of the pathophysiologic abnormalities that are associated with this. And this is the central illustration from that paper. And what we think is going on here is that, as I've mentioned already, women who have hypertensive disease of pregnancy or other APOs have risk factors pre-pregnancy in many cases, in most cases. That leads to a set of placental vascular abnormalities that includes abnormal villus maturation, avascular villi, perivillus fibrin and thrombi, periangiogenesis, and placental malperfusion. And this combination of factors seems to be not only associated with, but probably causal for adverse pregnancy outcomes. And as I've shown you, that adverse pregnancy outcome is then associated with abnormal cardiac mechanics. We find evidence of in other studies of coronary endothelial dysfunction and loss of arterial compliance. And the risk factors themselves, sedentary behavior that may be associated after pregnancy, plus all of these abnormalities seems to lead to overt cardiovascular disease down the line. This is a bit of a complicated slide, but it tries to depict that women who have adverse pregnancy outcomes have ischemic placental disease due to the factors that I mentioned earlier, other factors like oxidative stress and some biochemical abnormalities, such as elevated S-FLIT and endocrine and other inflammatory mediators seems to lead to the long-term consequence, hypertension, proteinuria, etc. The reason I put in this slide is that it's kind of disappointing to delve into this literature and recognize that aside from the one study that I just showed you from the JACC that was published in this year, there's really only a handful of other studies that have looked at cardiac structure and function following adverse pregnancy outcome. And what you'll see here, obviously there's too much text to take in here, but I want to point out a couple of things. Here's a paper from 2016 that was looking at serum biomarkers associated with global longitudinal strain in 62 women with preeclampsia, 40 women with gestational hypertension, and 105 women who didn't have an adverse pregnancy outcome. So a small study looking at global longitudinal strain from 2016. Here's another study from 2012. You can see again, the numbers are incredibly small. Study from 2015, a larger number of people here, 400 with an echocardiographic assessment of LV structure and function in women who had at least one hypertensive disease of pregnancy, and paper from 2011, again, very small numbers. So, and most of these studies have looked at women relatively early after adverse pregnancy outcome. There are almost no longitudinal studies. In fact, I could say that more categorically. There are no longitudinal studies that are published that look like the, Framingham study for women, trying to understand over the life course exactly what happens after adverse pregnancy outcome. Okay, so in the last few minutes here, I want to talk about some next steps that we might all consider related to this topic. I'm only going to be able to gloss over some of this in the few minutes that we have here, but I would point out there's a really very nice paper in JACC published in 2020 by the ACC Cardiovascular Disease Women's Committee. And this paper summarized the various updated recommendations for primary prevention of cardiovascular disease in women. And it's a really, really comprehensive, nice paper that gives, I think, all of us direction of what to do to try to reduce some of these long-term risks of cardiovascular disease in women. And as we all have become familiar with JACC has a central illustration in each of their papers. And this paper points out that obviously, for both men and women, we need to pay attention to the traditional risk factors. But for women in particular, we need to be aware of the other factors, such as adverse pregnancy outcomes, autoimmune diseases, et cetera, and also pay attention to some of the hormonal factors, such as premature menopause. Also, for men and women, paying attention to social determinants of health and psychological risk factors. And the concept that they present is that all of these factors are associated with the subsequent development of cardiovascular disease, possibly through inflammation, endothelial dysfunction, subclinical atherosclerosis, etc. And one of the figures in the paper is, again, a very nice summary of the specific cardiovascular conditions in women that we should be asking about when we see women for cardiovascular disease risk assessment. So the usual factors, smoking history, physical activity, but also what about breastfeeding? What about medical history of hypertension, diabetes, cardiovascular disease, and so forth. And what I found particularly interesting about this paper, which is a little bit unusual and might require a change in our medical practice, is trying to recommend to women after their pregnancy, particularly women who have an adverse pregnancy outcome, that they undergo early in the postpartum period a cardiovascular risk screening, because as we all know, what tends to happen to young women is that they're seen during their pregnancies and often not seen again until much later in life, when they've already unfortunately experienced adverse development of increased weight, hypertension, and other cardiovascular risk factors that could have been attended to earlier. So this is my second to last slide. My conclusions, I think it's clear from what I've talked about before, heart disease and vascular disease after APO is a very well recognized occurrence now. The guidelines have increasingly recommended obtaining pregnancy history and being more assertive in risk factor treatments in women. Hypertension after a hypertensive disease of pregnancy is very, very common and should be anticipated and treated. Various cardiac and vascular abnormalities have been shown in small scale studies. No major long-term studies published yet. And a suggestion that cardiologists and OBGYNs should be working more closely together. And last one, you've heard this before, more research is needed. And before I stop, I just want to give a plug to this study and urge you to consider getting involved. So my particular involvement in this topic area started about 5 years ago when I got involved in this study, which was known as the New Mom to Be Heart Health Study. So the New Mom to Be study was a study of 10,000 women who had 4 study visits during their pregnancy. They were seen each trimester of pregnancy. They were examined during those visits, and they had blood samples and urine samples that are available. They're stored samples. And pregnancy outcomes were documented in these 10,000 women from 8 different clinical sites. And subsequently, the National Heart, Lung, and Blood Institute got involved in this study and funded a follow-up study, which was known as the Heart Health Study. And we ended up successfully examining 4,500 women who were seen 3 to 7 years after the first pregnancy. And in this study, we were able to document what had been shown previously, that women who had adverse pregnancy outcomes had higher BMIs, they had higher blood pressures, and looked like they were on the road to developing cardiovascular disease, similar to what I've already shown. But that's not really all that novel. It had been already shown in other studies, but what had not been shown in other studies is what's really going on with these women. What are the cardiac structural abnormalities, the vascular abnormalities, the proteomic abnormalities, you name it. And we have succeeded in getting funding from National Heart, Lung, and Blood Institute for a subsequent follow-up study of these women. And we will be conducting an examination of hopefully 4,000 or more women from the original cohort during the years 2022 to 2026. We will be seeing the women face to face, and that presents opportunities for ancillary studies of all sorts, non-invasive studies of cardiac abnormalities and so on. We do have a number of ancillary studies that have already been funded, but if you're so inclined, I'd be happy to talk to anyone about new ancillary studies that could be included in this next examination of this cohort. So with that, I think I've left a decent amount of time for questions, and happy to take questions.
Okay, Phil, thank you. That was really tremendous and really eye-opening, certainly for me, about both the magnitude of the problem and the opportunities here for I guess, primary prevention. So I have a couple of quick questions for you. One of the things I'm not clear, and maybe the field is not clear either, but maybe you could comment on, are the adverse pregnancy outcomes here a marker of underlying pre-existing risk, or are they serving as a trigger to generate new, basically a new risk factor for these women?
Thanks, Jeff. It's a great question. And I don't think anybody really knows the answer to it, because for the most part, the women that are studied, even in the new mom to be study, the 10,000 women that I mentioned, almost all of them had no previous examination. The Cardia study, I think probably most of you are familiar with the Cardia study. Cardia study is the coronary artery risk development in young adult study. It's a study of about 4,500 men and women between the ages of 18 and 30 who've now been followed for over 30 years. So it's been shown in that study and other studies that women who have adverse pregnancy outcomes do have higher cardiovascular risk factors before the pregnancies. But like, what exactly is going on with that? And one of the things that we're doing right now with stored blood samples from the new mom to be study, the pregnancy study, is we're doing untargeted proteomics to try to understand whether there are circulating protein differences in women who eventually did develop an APO compared to women who didn't develop APO. And those samples are from the first trimester, before the onset of preeclampsia. So what we're hoping to see is that there may be some clues to what's leading to preeclampsia in first pregnancy. But your question's a good one, and it's kind of still being sorted out.
Great. And the other one, if you could comment on, I think it's almost an embarrassment, the slide that you presented about the excess mortality or excess mortality, I think, related
mortality,
to pregnancy in the US compared to our peer nations.
Um, well, this is totally speculation on my part, but you know, I think one of the things I didn't pay much attention to in my talk is some of the um, uh, differences in mortality rates among different um, social, economic groups and racial, ethnic groups. And there are large differences. And I don't think we're doing as good a job as we need to do before pregnancy, and particularly in lower socioeconomic groups and some racial ethnic groups in particular. But part of it is that women in the United States have hypertension rates that are too high before pregnancy, and rates of obesity that are high. And as you're well aware, many women, their first contact with the medical care system is pregnancy, which is probably late in the game.
Okay. So do we have other questions for Dr. Greenland?
Looks like there's some people with hands up.
Oh, okay.
Hi, Dr. Greenland. Hi, this is Michael Paytas. Thank you so much. I'm in the Department of Obstetrics and Gynecology, and really enjoyed your talk. I have just a comment and a question. So I spent about 10 years doing very large epidemiologic studies with the Danish cohorts, and really looked at a number of these endpoints and the exposures, the hypertensive disorders, et cetera, in preterm birth. And what I just wanted to comment on is we now have a beautiful opportunity to look at different sets to really to make the arguments clear about hypertensive disorders. So we have the US cohorts, which really have, as you have mentioned, basically a less cardiovascularly fit group, more or less, than, for example, the Danish cohorts, where people have less obesity, less smoking, more aerobic exercise. And just to say, we looked at those cohorts, first and second pregnancies, about 13 million patient years worth of data. And the point I wanted to make is, in first and second pregnancy, the correlations are quite consistent. The worse the exposure on the adverse pregnancy outcome, the worse the outcome subsequently between them with respect to the metabolic syndrome and cardiac endpoints. And so the question about pregnancy itself, this is what we were trying to get after. Is it going in, like with the Hunt studies, the risk factors that are simmering, or is it something actually in the pregnancy? And from our data, we've shown that actually there's, unless we've missed it, but we screened out all, as best we can, any diseases using all the registries. So these are otherwise healthy women, and those outcomes are worse in those women. So it's not going in so much, it's actually something about the pregnancy. And I was a reviewer for the new MOB-to-be, and congratulations. I'm so glad that it's being done here and continuing, that NHLBI is continuing to fund this really important study. My comment and question for you is the issue about the change in the guideline with the hypertension criteria. And we're struggling with this right now. There have been some studies that have come out that have not shown any demonstrable changes in the outcomes. So if we change the criteria for high blood pressure, if we go down to the 130 and not the 140, so this is a conversation that I think it would be really great if we had, as you mentioned, working together, because this is really going to be consequential as we look at longer term, effects and the interventional trials. So thank you for this great lecture, and I hope we do collaboratively work together as you suggested.
Thanks for those great comments. And I'm really glad that you were a reviewer on the grant application. And we're really excited to be able to continue this. And I'd be happy to connect with you afterwards.
Likewise, thanks.
All right.
And glad to see some OBGYN presence at this lecture. Thanks a lot.
My fellows are here too.
Terrific. Thank you.
All right. So any last questions before we're okay, Steve, did you have a question? No. All right. So we're at 8:30. Phil, thank you so much for I think really a eye-opening talk, and I think that hopefully some of our fellows will take up an interest in this wide open area. And as you see, we have interest from the OB department. Dr. Paitis and I, who share offices next to each other, so there's a natural connection there as well. And so thank you again, and we'll look forward for a lot of new and interesting ideas from in this area.
Hope so. Thanks a lot.